be discussing the preventions of mother-to-child HIV transmission in South Africa and how we can avoid the transmissions. There is a high probability of HIV positive infants that's dying by the age of 12 months, which is why I would like to inform you of the research studies in HIV positive infants than in HIV exposed but negative infants. The researchers are trying to detect the early introduction of infant HIV testings that identifies a large number of HIV negative infants who have been born to HIV positive mothers. During the studies of the Prevention of Mother-to-Child HIV Transmission Program, offered pregnant women HIV testing through the routine health care system and tested using ELISA antibiotic tests. However, the HIV positive pregnant women were not offered the ARV treatment. Trained fieldwork researchers conducted home visits at 3 weeks, 24 weeks, and 36 weeks post-delivery. These visits gathered data on infant diet, cessation of breastfeeding, child care practices, social demographic data, health status, and health visits for mother and baby. They would also collect dried blood spots for HIV status viral load from all study HIV positive mothers and their infants. The researchers described and compared the maternal, social demographic, medical, and infant characteristics of 3 groups of infants. First one is HIV infected in early 3 weeks infants. Second is the HIV exposed but negative infants. Third is HIV negative infants born to HIV negative mother. Here are some options to prevent transmission of HIV from mother to child. The high mortality of infants with unknown HIV infection or early suggest the screening for HIV infection through the use of PCR. Recent studies shown infants who initiated on early antiviral treatment before 12 weeks showed a 76% reduction. Alternative screening such as at birth or postnatal visits with the first week of life also needs to be done. Another option is to develop risk procedures to identify at high risk of being infected by offering early screening at birth. Researchers do believe there is a good reason to believe that among HIV exposed but negative children can be kept low if they are receiving prophylaxis, which will reduce it by at least 40%. In conclusion, we need to understand the importance of mortality of profiles of differences, groups of HIV exposed and unexposed infants. That is scaling up in South Africa. To improve child survival there needs to be a more effective prevention of mother-to-child transmission prophylaxis regimens, which would reduce it by less than 5%. It is also important to build capacity to access HIV diagnosis at 6 weeks immunization so that children with unknown HIV status is reduced. I think we can all agree a greater focus on prevention of early infection and screening for HIV infection in infants is recommended. Thank you.